We were meant to have 4, but we've got 1 presentation that has not been confirmed. So we're likely to have 3, but if anything changes, I'll let you know. So to start off with, we've got a presentation from Luc Delarive, and he's going to speak on population pharmacokinetic modeling of doravirine in real-life patients living with HIV. Please come forward.
Thank you. So hello, everyone. Today I will be presenting my study on doravirine, which is a treatment used to treat HIV. We did a population pharmacokinetic analysis of in real-life patients living with HIV. I'm Luc Delarive. I'm a 6-year medical student, and yeah, this was done as part of my master thesis. And a special thanks to Professor Girardin, Dr. Guidi, and Paul Touet. Okay. So first of all, what is doravirine? So here we have the molecular structure of doravirine. And doravirine is a non-nucleosive reverse transcriptase inhibitor antiretroviral drug used to treat HIV in combination therapy. It's an effective and safe drug compared to other HIV treatment standard of care. And it's metabolized by cytochrome 3A4 as oxidative metabolism. And therefore, it's susceptible to drug-drug interactions, especially with co-medications that influence, that either induce or inhibits cytochrome 3A4. Doravirine pharmacokinetics was only studied on clinical trials individuals, and that's why in this population pharmacokinetic analysis we decided to analyze doravirine's pharmacokinetics properties in real-life patients living with HIV. So first of all, our study was validated by the Swiss HIV cohort study, which was founded in 1988 and is a study based on the collaboration of many Swiss hospitals, so all university hospitals and some smaller hospitals, as well as affiliated laboratories and private physicians caring for HIV patients. In 2021, about 10,000 active patients were within this study, and 300 to 500 patients are added every year in this study. This Swiss HIV cohort study allowed us to do a population pharmacokinetic analysis on these study populations. So we had 146 patients living with HIV, which provided 174 doravirine concentrations. Here we have the characteristics of our population. So we can see that we had the majority of males, majority of Caucasians. The median age was 55 years old. The median BMI was 26, and relative to CYP3A4 co-medications, we can see that 24% of our data took strong CYP3A4 inhibitors with doravirine, and these included cobicistat and ritonavir, which are HIV boosters. And those are all the covariates that we analyzed in our population pharmacokinetic analysis. So first, about this analysis, first we started by identifying a structural-based model. So we did a stepwise procedure where we analyzed different types of models, and in the end, we ended up with a one-compartment-based model with linear absorption and elimination, which is a very standard pharmacokinetic model represented here. So doravirine is absorbed into a compartment and then eliminated linearly. We then did the covariate analysis. We started with the first univariate analysis at a p-value of 0.05, and then a stepwise multivariate analysis at the p-value of 0.01. With this, we identified statistically significant covariates and ended up with our final model. This model was internally validated by the visual projective check method and the bootstrap method. Regarding the final model more specifically, we found that only the age and the strong CYP3A4 inhibitors covariates statistically significantly affected doravirine clearance. And this is the final equation of our model. So doravirine clearance of an individual was equal to the typical value of doravirine clearance times the effect of strong CYP3A4 inhibitors times the effect of age, and age was always compared to the median age, which was 55 years old in our study. What this means concretely is that a patient taking strong CYP3A4 inhibitors with doravirine compared to a patient that does not take strong CYP3A4 CYP3A4 inhibitors with doravirine had a 50% decrease in doravirine clearance. And about the age covariates, an 80-year-old patient compared to a 50-year-old patient would have a 30% decrease in doravirine clearance. We can clearly see that these two covariates affect doravirine's clearance. With this final model, we use the final model's estimates to perform simulations on doravirine plasmatic concentrations on groups of 1,000 virtual individuals. So here we have the predicted effect of strong CYP3A4 inhibitors on doravirine concentrations. On the x-axis, you can see the time after dose administration of doravirine in hours, and on the y-axis, the concentration in nanograms per milliliter. Logarithmic scale is used. And here we can see two groups of patients. The purple ones take concurrent strong CYP3A4 inhibitors with doravirine, and the green ones don't take concurrent strong CYP3A4 inhibitors with doravirine. Each group has a median concentration, which is the bold line, and the thin lines are the 95% confidence intervals. And here we can see that that doravirine exposure is higher in patients taking concurrent strong CYP3A4 inhibitors compared to those that do not, which is expected. Regarding efficacy and safety, we used an in vitro study that proved a 33.3 nanograms per milliliter efficacy threshold, and at 24 hours time after dose. And here we are much higher, so doravirine was at effective concentrations in our study. And for safety, safety studies have shown that an increase of 3 to 6 times the area under the curve from 0 to 25 years old, 24 hours, sorry, was safe, and that no adverse effect appeared at these exposures. And here we had only 2 times doravirine exposure in patients taking concurrent strong CYP3A4 inhibitors with doravirine. So we were as well within safety margins. We then did this simulation, which is a theoretical dose adjustment in patients taking concurrent strong CYP3A4 inhibitors. So the green individuals are taking doravirine once daily without the effect of concurrent strong CYP3A4 inhibitors, which is a regular posology. And the purple individuals are taking concurrent strong CYP3A4 inhibitors with doravirine. However, we made a dose adjustment where we gave doravirine once every 2 days. And what's interesting here is that at the time of the dose of 48 hours, the median and 95% confidence intervals of these two groups of individuals are almost the same. And that's because, as I've shown before, strong CYP3A4 inhibitors reduce doravirine clearance by exactly 50%. All of these simulations were done at steady states. And finally, we predicted the effect of age on doravirine concentrations. Here, we simulated two groups of individuals, the young individuals, which are aged from 25 to 65 years old, and the old individuals, which are aged from 65 to 80 years old. And we can see that doravirine exposure is higher in older patients. It's worth noting that the effect of age was smaller than the effect of strong CYP3A4 inhibitors on doravirine clearance. So about the discussion, was doravirine at effective and safe concentrations in this study? Well, as I've mentioned, yes, it was. Were these results coherent with other doravirine population pharmacokinetic studies? Well, yes, other population pharmacokinetic studies have shown the statistical significant effect of age and strong CYP3A4 inhibitors on doravirine clearance. However, they weren't judged clinically meaningful. Yeah. And that's what we also found in our study. Therefore, no dose adjustments are required when giving doravirine to an old patient living with HIV, or to a patient living with HIV taking doravirine with concurrent strong CYP3A4 inhibitors. And therapeutic drug monitoring is not indicated in routine clinical care for doravirine. However, in specific cases, such as pregnancy, which has unique physiological changes, or conditions that affect doravirine absorption, for example, bariatric surgery or inflammatory bowel disease, doravirine pharmacokinetics might be affected, and therefore therapeutic drug monitoring might be useful. Also, in non-adherent patients, therapeutic drug monitoring could be useful to objectify non-adherence, short-term non-adherence to the doravirine treatment. So in conclusion, we found comparable results in real-life patients living with HIV compared to clinical trial individuals and or healthy volunteers, which is reassuring. No dose adjustments or therapeutic drug monitoring are required for doravirine in clinical practice. However, keep in mind these special cases where therapeutic drug monitoring might still be useful. Thank you for listening, and if you have any questions, please let me know.
Thank you very much for that presentation. I can now invite questions. Please feel free to use the mics on either side of the benches. If there's anyone with a question. Okay, I think everything was crisp and clear. Thank you.
Thank you so much.
So I'd like to just check if our missing presenter is here yet. Do we have Dr. Abimbola? Okay, I think they are not here. So we'll have to move on to our third presenter. Dr. Martinez, please come through. Dr. Martinez is from the University of Hospital Clinic of Barcelona, and she's going to speak to us about adherence to direct oral anticoagulants in atrial fibrillation patients. And this is a real-world study in 2 populations in Spain. Over to you.
Good afternoon. My name is Lina. I am here today for the presentation of the preliminary result of the study adhering to direct oral anticoagulant in atrial fibrillation patients, a real-world data study into population, Catalonia and Valencia, Spain. Atrial fibrillation is the most common heart rhythm disorder worldwide and has a major impact on public health due to the increased risk of stroke and hospitalization. Therefore, no adherence to oral anticoagulant in patients with atrial fibrillation may result in a higher risk of adverse outcomes and has been shown in several studies. Several observational studies has been conducted to estimate adherence to oral anticoagulant in the real world. These studies have used pharmacy claimed databases of electronic health records. However, the efforts used to distinguish adherence from non-adherence are usually based on aggregate value or the entire observation period. They don't take into account variation in adherence over time. Therefore, traditional adherence measures, such as the percentage of day coverage, are ineffective in determining differentiated behaviors. This study aims to characterize the adherence pattern or new user of DOAC in patients with atrial fibrillation and to identify factors associated with no adherence using real-world data from 2 populations in Spain. In this figure, you can see an overview on the study that is the design. We conducted a retrospective cohort study by identifying new users of OAC among patients with atrial fibrillation into population in Spain, who were newly prescribed a DOAC from January 1st, 2012 to December 31st, 2018 in Catalonia, and from January 1st, 2012 to December 31st, 2017 in the region of Valencia. Patients were followed up for 1 year from the first drug prescription date. We used 1 year look-back period to define baseline patient characteristic and to exclude prevalent OAC user. The study was conducted in the population covered by Catalan health system, 70.5 million inhabitants, and Valencia health system, about 5 million inhabitants, which are part of the Spanish national health system. I would now like to present to you preliminary result that we have come up with, and the final and complete result will be published in a paper currently being worked on. The flow chart of the selection of the study population in the two cohorts, Catalonia and Valencia, is shown on this slide. We included adult patients with undiagnosed atrial fibrillation or atrial flutter who started treatment with DOACs, dabigatran, apixaban, edoxaban, or rivaroxaban for the prevention of the thromboembolic event during the recruitment period. In each population, we excluded patients with concomitant diagnosis related to mitral valve disease or mechanical heart valve, indication for DOAC due to hip or knee arthroplasty, and non-naive to oral anticoagulants. Patients with registry anomalies, DAF data before the prescription data, and prescription of 2 or more different DOACs, and patients with limitation of follow-up. No resident, no pharmaceutical coverage also were excluded. The study included 22,632 and 19,616 new users of DOAC with atrial fibrillation during the study period in Catalonia and region of Valencia, respectively. Overall, in both cohorts, the most used DOACs are apixaban and rivaroxaban. Atrial fibrillation is the most common diagnosis in both populations. In both cohorts, mean age is 73 years, and age rank with the most patient is 75 to 84 years. The majority of patients in Catalonia cohort were female compared to the Valencia cohort, where the majority of patients were male. This slide shows the trajectories. Sorry. The table shows that hypertension, diabetes, and vascular disease were the most common comorbidities in both cohorts. Other comorbidity diagnoses were included but are not shown in this table. Only those with more than 10% in either cohort were included. This table shows that the risk bleeding is high by more than 50% based on the Hasblee score in both populations. More than 5 concomitant drugs were prescribed to more than 50% of patients during the follow-up periods. And more than 80% for patients and low coinsurance. Coinsurance is expressed as percentage of total cost of prescription to be paid. I will now present to you the preliminary adherence result that we have obtained. We first calculated adherence using PDC based on prescription or dispensation during 1 year of follow-up from the index day. The threshold about 80% was considered the cutoff point for classifying patient as adherent. This threshold above with patient can be considered highly adherent for most classes of chronic medication. As seen in the table, the population of Catalonia is not adherent to dabigatran treatment compared to the population of Valencia, which is adherent and all drugs according to the PDC result. This slide shows the trajectories of adherent drugs in the first years after the initiation of drug. Adherent trajectory we calculated using the Latin classes and Latin process, the R package. A grid of parameters was used to determine a best trajectory model. Specifically the polynomial degree 2, 3, and 4, and the number of classes 2 to 6 were tested. The final model was selected using Nagin criteria and lowest Bayesian information criterion, mean posterior probability more than 70%, a minimum proportion on the study sample in class group of trajectory of 5%, and entropy equal or more than 0.75. Different adherent patterns were identified. In Valencia region, 3 trajectories were obtained. Fully adherent, 82.7%, high adherent, 12%, and early decline, 5.3%. In Catalonia, in addition to this trajectory representing 62%, 14.5% and 66% on the core, respectively. And late decline in adherence trajectory was also identified, 6.8%. Factors associated with adherent trajectory at 1 year follow-up in both cohorts are shown on this slide. In both cohorts, multinomial logistic regression was performed to assess the association between baseline characteristic and membership with identified adherent trajectory. The class with full adherence to drug therapy was treated as the reference group. The factor associated with early decline in both cohorts include the use of dabigatran, high coinsurance, and alcohol. Other factors associated with early decline include transient ischemic attack in the Catalonia cohort, in the use of rivaroxaban in the Valencia cohort. In addition, factors associated with the late decline in Catalonia include high coinsurance, venous thromboembolism, transient ischemia attack, and the use of dabigatran. This result showed that trajectories can add more information and better discriminate between individuals with different adherent behaviors. In conclusion, applying group-based trajectory model to data from the cohort of patients with atrial fibrillation, an indication of therapy with indirect or oral anticoagulant in Catalonia and Valencia during 1 year of follow-up. We describe 4 and 3 trajectories of adherence to the drugs in the Catalonia cohort and the Valencia cohort, respectively. We identify common risk factor for both cohorts associated with no adherence during the first years of treatment. This includes use of dabigatran, high co-insurance, and alcohol. According to the result obtained with the PDC, the population of Catalonia is not adherent to treatment with dabigatran compared to the population of Valencia, which is adherent to all drugs. I would like to thank all the members of the team who are working with me to carry out the study. And thank you for your attention.
Thank you, Dr. Martinez. Anyone with questions? Yes?
Hello, thank you very much for a very interesting presentation. I've just got a question about PDC as a measure of adherence. Do you think that that's a best measure of adherence in that some patients may pick up prescriptions but they don't use them? Is there a better way to look at that? I'm asking this because around the 90 million pounds or 190 million pounds or 100 million euros is estimated to be sitting in patients' home in the UK every year of unused medicines. So patients pick up their medicines and they don't use them. So is PDC the best measure of adherence, and can you think of ways that we might improve adherence research?
Yes.
Do you want me to repeat the question?
Yes.
Sorry.
So she's questioning your measure of adherence. So to determine whether the patients were adherent or not, do you think PDC is the best measure to determine adherence?
Yes. Have outcome. Is the moment the second part, the study, the relationship between factor associated and with adherent trajectory and health outcome will analysis in second part of the study. It is important to identify chronic medication not adherence, no medication not adherent groups or partners. This can help to plan intervention for these groups of patients in the order to improve the effectiveness and safety on the treatment.
Okay, thank you.
Any other questions? Please go ahead.
Yeah, thanks for your talk, Paul Chen from New Zealand. I'd just like to, can you speculate about why dabigatran was associated with less adherence compared with the other anticoagulants? What's the reason that you think dabigatran performs worse?
So the drugs that you assessed, there were differences in the adherence between the drugs. Do you have any explanations why it was easier to adhere to one drug over the other?
Is the moment no the result we have so far the more analysis for differentiation result and the docs.
Okay. I don't know if I understood correctly. Others can weigh in, but she's saying what she presented is preliminary analysis. There's more analysis that's going to come that will be more detailed and explain maybe some of the variances. Okay.
Yes.
Thank you very much. Thank you.
Thank you.
Do we have our third presenter? So next we've got Dr. Emile, and she's from Toulouse.
In France.
In France, yes. And she's going to present to us on perception of medical cannabis and other cannabis-based products by multidisciplinary healthcare professionals across Europe. And this is a research that was conducted by the European Association for Clinical Pharmacology and Therapeutics, early career pharmacologists.
Thank you very much. How can I have the... Okay, thank you. So thank you very much. I would like also to thank the organizing committee for giving me the opportunity to present this collaborative work on behalf of the EACPT Early Career Clinical Pharmacologist Working Group. This working group has been created back in 2015, and the functioning, we meet on a regular basis, once in 2 months or about, and we meet physically before each EACPT Congress. Membership is free, and we welcome any motivated new people willing to help and contribute. I co-chair this working group with Carla Sanspolda from Spain. Currently, we are between 15 and 20 active members from all over Europe, including from countries outside of the European Union, UK. Our activities can be summarized by 3 cornerstones: mobility, education, and research. The previous chairs, who were Pau Alcobilia from Spain and Isabella Ekeden from Sweden, they initiated this new axis for the working group, and they really wanted to have research in the working group. And so this is what I'm about to present you. My objective today is telling you the story of the first collaborative working research project within the working group. So at the beginning, we observed that significant changes in cannabis regulation occurred across European countries. And these changes accelerated over the last decade. And indeed, cannabis switched from a fully illicit drug to a drug authorized for medical purposes or even in a recreational context. So this included kind of confusion, and the situation is particularly confusing in Europe, where a variety of situations exist depending on national laws. So in the general public, we can have cannabis may be seen either as a safe treating drug or as a substance whose use is punishable by law. And we assumed that among health professionals, we could, as individuals, have also very different views on the same drug. So our objective was to assess the perception of medical cannabis and more widely of cannabis-based products among multidisciplinary healthcare professionals across Europe. To reach this objective, we implemented a cross-sectional survey. The target population was that of all graduated healthcare professionals likely to be involved in the prescription, dispensing, administration, or advice of medical cannabis and working from all over Europe. The study ran from February 2021 to September 2022 and was based on the distribution of an electronic questionnaire that was made available on the European EU survey platform. We then conducted a statistical descriptive analysis of the entire dataset. A total of 196 questionnaires were collected, and among these, 179 could be included in the analysis. The mean age of participants was 40 years old, with more women than men. Participants were pharmacologists, nurses, GPs, internal medicine physicians, pain physicians, pharmacists, and oncologists, and so on. They started their career 11 years before, as a mean, and they mostly worked in hospital in urban areas. They originated from 15 different countries, and you can see here the geographical distribution. The majority consulted less than one patient treated with medical cannabis or cannabis-based product each week, and they had never prescribed medical cannabis. Besides, 33% of them supported the legalization of recreational cannabis versus 42% who did not support it, while 23% had a neutral opinion on this question. On this graph presents the participants' views on the contribution of medical cannabis to the current therapeutic arsenal. So here you have the green areas which correspond to agreement, roughly, gray areas to no opinion or balanced opinion, and orange areas corresponding to disagreement. So the participants thought that medical cannabis could add an added value in chronic cancer pain, in neuropathic pain, in multiple sclerosis, nausea, vomiting following chemotherapy, and chronic non-cancer pain. On the other hand, they didn't feel that it could have any added value in addiction, depression, or anxiety. Then we proposed them a list of statements and asked them to rate their level of agreement with each of these statements. As you can see here, most of them pretty agreed with the statement, I believe that medical cannabis is a legitimate medical therapy. Also, they reported feeling comfortable discussing medical cannabis and even recreational cannabis with their patients. However, they reported they believed to have insufficient knowledge to prescribe or dispense, administer, advise medical cannabis to their patients. Unfortunately, the number of included participants was tenfold lower than expected. In this survey, the distribution strategy was based on indirect sending of the questionnaire, because we contacted European learned societies who were supposed to distribute the questionnaire to their affiliated members. We also sent regular reminders and had 2 extension periods. When we were facing the difficulties in recruiting participants, we made some adjustment to try to reach more participants, and this introduced selection bias. So consequently, the results obtained from this survey only reflect the opinions of those healthcare professionals who effectively participated and may not be extrapolated to the target population of the entire European multidisciplinary healthcare professionals. To provide you with some example of factors that could have contributed to non-participation, the questionnaire was in English exclusively and not in national languages, so this could have participated to non-participation. Also, the questionnaire was very long. It is possible that the people who received the questionnaire were reluctant to share personal opinions about a drug that remains illicit. And lastly, maybe they lacked interest in the research question and felt not being concerned, in particular in countries where medical cannabis is not available. There are previous data available on healthcare professionals' attitudes or knowledge towards medical cannabis, but these previous studies were focused on prescribers only or on one specific medical condition, such as cancer or neuropathic pain, for example. And also, these previous studies were conducted outside Europe, in the United States or Canada or even Australia. So despite limitations, the present survey is the first one to assess the perception on medical cannabis of all healthcare professionals working in Europe without restriction on one specialty or one disease. And thus, it provides elements on the level of acceptability for cannabis as a therapeutic option. Overall, in our sample, cannabis appeared well perceived and well accepted by the participants. And these first results can serve as a basis to implement future actions at the attention of healthcare providers, including, for example, education. And now, if we take a step backward to have a wider vision, this first collaborative research project plays an essential role because networking around one common, unique research project is a way to have the working group strengthened. And indeed, a formal structuring of this working group is essential to ensure stability in the middle and long terms. Before concluding, I would like to acknowledge all the members of the working group. The picture has been taken last year in Athens. We had a very brainstorming and working and fascinating afternoon with over 70 participants. Well, we have come a long way since 2019. And so I would like to thank the members that are here today. And also because it's also my role as the co-chair of the working group, I repeat it, but we are constantly welcoming new motivated early career members. So if you feel interested, please don't hesitate to contact us. This QR code is my visit card with a direct link to the web page of the working group on the EACPT website. Thank you very much for your attention.
Thank you for your presentation. I'm sure there'll be questions since this is cannabis. Yes, you can start.
Hello, thank you for your talk. It was great. I have a question about, you said that this research was conducted from opinions of professionals and healthcare professionals, and some of them strongly disagree with this idea. So what if the survey was made from just normal people, and don't you think that this will give people more of a reason to be addicted to this and or trigger addiction?
So I think there are two questions in your question. So the first one, if I understand well, is are there differences between healthcare professionals, the population of healthcare professionals, and that of general population? Yeah. Well, for this, actually, I don't know. It would be very interesting to raise the question. And I don't have any answer about this because we didn't ask people in the general public. And then the second part of the question is about the risk of having people inducing abuse or addiction to medical cannabis. Well, actually, the doses are not the same, and the treatment with medical cannabis is regulated with the administration route is not the same either. And right now, for example, in France, because I'm coming from France, we have an experimentation for medical cannabis, and there is no signal of any diversion of the drug. But the data coming from elsewhere and based on more on the general public surveys these data report that the people under medical cannabis are also recreational users of cannabis. The co-use is very frequent, but in Europe, I don't know, at least in France, I know we don't have this signal.
One more question. So what if the use of medical cannabis will kind of convince people that the other use of it is normal rather than just medical use?
Yes, and this is in relation with what I was saying just previously. We can see in surveys asking general public about their use of, well, some of these studies have been conducted in people using CBD, for example. And in the questions, it is asked if they also use recreational cannabis, and it's the co-use is very frequent.
Okay, thank you.
Thank you.
Thank you. You can go ahead.
Hi, I am clinical pharmacologist from Germany, and I am wondering if you have seen any difference between different countries. I can imagine that a physician in Netherlands maybe thinks differently about cannabis in compared to a physician in Germany.
Yeah.
Have you analyzed that or not?
Well, that is what we intended to do, but unfortunately we only had, well, we had less than 200 participants, so we had, well, I'm exaggerating, but we had maybe more questions than answers, but that's, and so unfortunately we were not able to do all the statistical analysis that we intended to do because of the lack of power. And so it would have been so interesting. It was one of our secondary objectives. But unfortunately, we don't have enough people participating. And so it's not possible to do it.
Okay, thank you.
Sorry.
Thank you. Any more questions on medical cannabis? Okay, thank you very much.
Thank you.
So I'll just check one last time if Dr. Bimbola is now in the house. Okay, so I think that is it for today. Thank you very much for engaging and for all the presentations.